Hello, all. Good evening. Welcome and happy Independence Day to all of you.
Good evening, Dr. Abhishek. Good evening,
Good
everyone, and
evening,
a very,
brother.
very
Good
happy
evening.
Independence Day to all the Indians from around the globe who are watching us.
Today we have a big day. We are in the last league of Endo Masterclass, and we have a very talented, young, and dynamic Dr. Chopra with us. Good evening, sir, and welcome to Endo Masterclass.
Good evening, Abhishek. Good evening, Anand. Happy Independence Day, guys.
We have today so many people joining in so early and eagerly waiting for you, sir.
Alright, thank
I
you
can
so much.
see
It's
so
an
many
honor.
comments.
It's an honor.
Great, sir. Thanks a lot for accepting our invitation, sir. Just a brief introduction about Chopra, sir. So, Dr. Viresh Chopra, sir, is currently as a faculty of endodontology in Oman Dental College, Muscat. He finished his graduate studies from Subharti Dental College, Meerut, and he finished his post graduation in 2007 from India. He was practicing exclusive endodontics in Delhi before he moved to Muscat, Oman. He has published books and contributed to many books on endodontics. He has published various scientific papers in national and international journals. He is a key opinion leader for dental companies like Colteen and FKG. His key areas of interest are microscopic endodontics, retreatment, the topic of today, and regenerative endodontics. He has been invited for lectures widely all around the globe regarding magnification, retreatment, CBCT, dental healthcare in various national and international forums. He is on the international editorial board member and reviewer for many journals. He is currently pursuing his PhD from the reputed Queen's Mary University, London. Apart from dentistry, Sir has been an international player of fencing and has represented India in Asian Championships.
Oh,
He
wow.
is an active sportsman and has played state and district level tournaments in cricket and badminton. Wow. Reading books on philosophy and watching inspirational movies is among his few hobbies. Wow, sir. For the hobbies part, I'm gonna get in touch with you. Leave the dentistry aside.
Anytime, anytime. Me too, me too. That is my favorite part.
And I
Sir,
am I am
since
I
you
am out
mentioned
of both
cricket,
of it, huh? I'm,
and since you mentioned cricket, sir, MSD has announced his retirement just an hour
I
ago.
know, I know. It's the latest
Suresh
news
Raina as
now.
well. Suresh Raina as well.
Suresh Raina as well.
Oh, oh,
Great.
And
Sad day for us today. For me.
yes, yes.
Chalo, sir. Bye bye. The stage
bye
is
bye,
all
sir.
yours,
Bye-bye.
sir.
Right. So you guys can see my screen?
Yes, yes, sir.
Yes,
All
sir.
set.
All set.
Okay. Good evening, everyone, and I would to all the Indians, happy Independence Day around the globe, and as well as to everybody from Indians to everybody, all happy Independence Day from our side. And first of all, I would really like to thank Dr. Abhishek, Dr. Saurabh, Dr. Anand for sending an invite and inviting me over for this lecture and conducting this extensive endo master class, which has actually covered all the aspects in endodontics, and I don't really think they have left anything. And they gave me, I took this topic of retreatment in endodontics and achieving success through failures. And today we'll be discussing few cases on retreatment, and we'll be seeing that how a failed cases that can actually become a success. Now, this topic is very close to my heart. Reason being, I really love retreating failed cases and taking up challenges, because somewhere I feel that whenever I see a failed endodontic case, that failed endodontic case is basically trying to tell me that you find an appropriate intelligent logic and use it to reach endodontic success, that there is some reason because of which this root canal treatment has failed. So it is my duty as a specialist or as a dentist, it is our duty when we receive these cases to look that what is the logic behind why it failed. That is there a perforation that happened, is there a missed canal, or whatever different reasons we get. So it is our duty to find the reason behind it. We need to do the pre-assessment of the tooth. We need to see the prognosis of the tooth. and then we need to decide whether it is savable or not, right? If it is savable, even 1% we feel, then probably we should see the appropriate reason for its failure and treat that particular reason. So this brings me to the aims of my presentation. Now, the aim of my presentation basically is not to tell you people that what are the reasons behind failure of endodontic cases, what happens, what are the major reasons, what are the minor reasons. These are all written in the books. So I don't want to actually bring the theoretical knowledge here and bore everybody here, because we can read it. And if it is in the books, there is no need for a presentation for that. But what I want to do here through my aims is to develop this characteristic where we can learn how to analyze failures and imagine that if this failure has happened from us, why it happened. If it has happened from our colleague, then what can be the reasons it must have happened, and then develop an impeccable style where we can see that whether we can treat these cases or not treat these cases. Now, many a times this happens when we get cases with certain perforations or certain mistakes that has happened. We feel that, oh, mistake has happened, this should not have happened. We start criticizing. But I would here advise and I would say that we should actually learn from these mistakes. Even if it has happened from us, we should see why it happened and to become better and to achieve success in our endodontic therapies. We all have read textbooks of endodontics, but which we call bibles in endodontics, like Engel, Cohen, and in BDS times we have read Grossman also. But I have always felt that there is something extra needed. When I say something extra needed, I don't mean to say that these books don't give us anything. They make our backbone of endodontics. They give us the main knowledge of endodontics. But what I feel is that we need something extra with which whatever backbone we have made from these theoretical books, after reading such extensive books, whatever backbone we have made, I always feel that we need something extra to make that backbone a bit flexible so that we can learn tips and tricks in endodontics. And therefore, I think this gap is very beautifully covered by another books in endodontics, which basically I called as Facebook of clinical endodontics and Instagramology of clinical endodontology. Because these social sites, we see such beautiful cases, but definitely it is our decision and it is our duty to recognize which case is good and which case is not appropriate, right? There are certain cases always which are not done very well, but they are shown to be done very well, or which the procedural steps might not look good to us. But anyways, we should be ready to neglect those cases and choose certain good cases which will give us good clinical experience. So whatever we read in the books these days, this social media shows our cases which we can relate to our clinic, and we can gain clinical experience, so that if we get a certain case like that, we are able to remember what we saw on a particular case on a social media, and we can try doing that. As I said, we have read books, and in the books we know that there are various causes that have been written for failures in endodontics. One of the major causes is missed canal, as we all know. Then others are perforation, instrument fracture, under obturation, over obturation, and so on. And all the whole literature says that these are the causes that cause failures in root canal treatment. However, if we see it technically, right, if we read beyond the failures, then the books also say that all these causes lead towards inadequate cleaning and shaping. This means if we do a perforation or if we do an instrument fracture, then the area where the instrument has fractured or the area beyond the instrument fracture becomes inaccessible to us for doing a proper cleaning and shaping. And that is when we leave space for microorganisms to develop and cause microbial infection. So technically speaking, the causes which I have listed above, they are actually, they do not cause the failures. The failures are only caused by inadequate cleaning and shaping. So this means even if there are good root canal treatment, good root canals which are visible on radiographs, they can also fail if there are certain regions which are not cleaned and shaped properly. You might see a very good obturation on a radiograph very nicely with a six taper you have prepared up to 30 number, and you have obturated a broad root canal, and it looks really good, but it might fail in future if cleaning and shaping is not done. The reason behind is there is no procedural accident, there is no missed canal, but cleaning and shaping has not been done properly, because we need to understand that we are basically not treating a root canal. What we are dealing with is a proper root canal system which comprises of ramifications, which comprises of accessory canals, which comprises of lateral canals. So that is why we are now from root canal obturations or root canal treatment, we are moving more towards three-dimensional root canal cleaning and shaping, three-dimensional root canal obturation, and three-dimensional sealing of the root canal system to achieve success in our endodontic therapy. Now, if we see dentistry as a whole, and especially endodontics, it has evolved a lot, and it has come far, it has traveled a long journey because of emerging newer devices and materials which help us to obtain success. That is particularly what I call as endo, right? Because we have magnification, we have endodontic ultrasonic tips, we have excellent materials to seal perforations, bioactive materials are there, so many things are there to help us to get the healing back, or not to make enough mistakes, or not to miss enough canals, so that we are able to obtain success in endodontic therapy. Having said that, still, as in this article, Eddie very nicely summarized that medicals and dental professionals, what we are walking on is a very slippery terrain, because we often get surprises. When you open a tooth, you might get surprised. What you are not able to see on a radiograph, suddenly you might see on the clinical picture under the magnification, or with a naked eye, if we are really lucky. So actually this shows that how poorly we understand science, right? How much ever far we come with the help of magnification, with the help of research, with the help of devices and materials, still there is always something which is missing, and we need to understand more about it. Now when I talk about slippery terrain, I would show you this case. Now you see a pre-op here. This is a retreatment case that had come to me with tenderness to percussion, and this treatment was done around 1 year back. So when it came, I frankly told, we had a discussion, and I told this case that it seemed to be a short obturation, and the tooth was tender to percussion. It was having a ceramic crown on it. Patient didn't want to lose that crown, so I told him that okay, we can try through the crown, but at the same time, during doing the excess cavity preparation or putting a clamp, crown might pop out, then we'll have to give you a new crown. This is my duty to tell the patient, so that tomorrow if the crown pops out, the patient is not in a position to blame me for that. So I told the patient, and he agreed, right? So we started making an excess cavity through the crown. Now let me tell you that making an excess cavity through the crown has its own challenges, because I really do not know what was the original shape of the excess cavity before. One, I really do not know how much originally the tooth was destroyed. Second, third, that I really do not know how the crown preparation has been done. So there have been certain cases where I have made an excess cavity through the crown, but the canals are present in a totally different direction other than where the crown is given. So the morphology is totally different where the pulp chamber should be. So my advice here would be, when you are making an excess cavity through the crown, please go really slow and try to see again and again, check yourself. Like here, I stopped after making excess cavity. I thought my burr is going really deeper, and I could feel the tactile sensation which we feel cutting ceramic is different, and cutting the tooth structure or a material, bonded material below that is different. It becomes gives a more softer touch. So I stopped here and I changed into using endodontic ultrasonic tips. Now, the idea behind using endodontic ultrasonic tips here is so that I am able to locate the gutta perchas. Whenever I am doing a retreatment through the crown, or through an artificial crown or a natural crown, my first aim is to find gutta perchas only, a sign of gutta percha, so that I can, it actually acts like a map for me to make my excess cavity, like we use dentinal map, right? So you can call it as a gutta percha map. So it acts like a map for me so that I am able to see gutta percha. And since I am using conservative instruments, I don't touch the walls of the excess cavity here and there. I am focused where I need to cut, and this is how I see gutta percha. Once I am able to see the gutta percha, I will use my rotary instruments, soften that gutta percha with solutions, and remove my previous gutta percha. Now I am using Endo Shaper from FKG because I really like this design of three-dimensional design of it. As you can see, it will throw the gutta percha out of the canal very easily, and then I can irrigate and reach to a stage where I am ready to place intracanal medicament. This is, you can see, clean canals, and I am placing intracanal medicament here. Once the intracanal medicament is placed, I do not I firmly believe that the intracanal medicament should be placed inside the canal, and the entire pulp chamber or the excess cavity walls need not be filled with the intracanal medicament. If you are doing your job well, cleanly, then probably you will control yourself from wasting material, right? Because materials are costly these days, so we need to avoid wasting of materials, and at the same time you will do a very clean endodontics. Next visit, when the patient came, I am ready for obturation. It's a straightforward case, and the patient also became asymptomatic, not tender to percussion, and I am ready for obturation. And when I take gutta perchas, dry the canal, I under magnification, I suddenly see this gutta percha hanging with the wall. Now, to me, there were two choices here. Since the patient is asymptomatic, I know that I am going in the right direction. So I can even leave this gutta percha because it's a small gutta percha hanging on the wall. I will seal it nicely. Patient is asymptomatic. But somehow, since I could see it very clearly, I thought of removing this gutta percha with an endo probe, which goes deeper, but it did not come out. So when it did not come out, I tried to just enlarge the mouth of this buccal canal so that I can make way for the gutta percha to come out. So I again went back to my endodontic ultrasonic tips, touching the area which I require to touch, and just slightly increasing the orifice or mouth of the buccal canal so that I make space for my gutta percha. And once that gutta percha came out, see what I saw here. I saw a buccal split, right? Now, the thing here is, what I want to emphasize here is, I would have also missed this canal because the patient became asymptomatic. So I thought that I'm going in the right direction. Gutta perchas, the master cone radiographs were fine, working length radiographs were fine, patient was not complaining anything. So there was, and I could see from the laws of the excess cavity also that my excess cavity was firmly, nicely made, right? So that to my satisfaction. And if I had not thought of removing that gutta percha from the canal, probably I would not have seen this canal also. So thankfully, I thought of removing the gutta percha from the canal, and this means I was again and again checking my work. So this is the advice I want to give, that we need to check our work at every stage. If the patient it becomes asymptomatic, that does not mean that we should leave the treatment there and continue. We should keep checking what we are doing, how it is going, and if we are using magnification, then we should keep looking for certain variations, and we should try to do whatever best we can. So once I saw this split verified on the radiograph, and you can see here that I have placed 10 number file, 20 number file, and a rotary file here, because I wanted to I could have placed an H file also, but I was using Revo from FKG to clean and shape the canals. So probably I placed that canal to verify the three canals, right? And I verified these three canals. Now the thing is, if you are using magnification or if you are not using magnification, what happens is, when we try to find this split with a 10K file and our hand comes in between, it blocks the vision, and whatever we try to do, it's a hit and trial method, that if it goes, very nice. If it doesn't go in the split, then we again try to find that extra canal way for that file. Now my advice here, it would be that if you can, please try using a locking plier, as I have used here. If you can see this video, use a locking plier, pre-curve your file, and under magnification, if you are using, try to find that orifice, place the file, push it with the same locking tweezer, and then remove the lock. Once it is inside the canal, this is now you can use your hand, because now the file, until and unless you bring it out, will not come out. So you can easily place the file inside and guide it towards the apex, and you can use electronic apex locators for working length and verify with a radiograph if you want to. Then you can see here in the master cone, I saw that there is a resorption which was actually not evident on other radiographs. So when I saw this resorption, I probably cut the gutta percha, adjusted the working length of the gutta percha, and I obturated the canals. So this is how the obturation has been done. Obturated the canals at the split, the buccal canals at the split, and the palatal canal at the orifice. So this is you can see how the obturation has been. And now I have recalled this with this I did 2 weeks back only. So I've recalled this patient to to perform thermoplasticized obturations in the remaining part of the canals, and then go ahead with the core buildup. Now the question, the idea behind showing this case is that, as I said, it's a slippery terrain we are walking on. We really do not know that where we will miss some details. So it's our duty to look inside, use magnification to give the best results as possible, and do our best to achieve success. Now, whenever I do a treatment, whenever I see a root canal treatment case or a retreatment case, whichever case is that, when I am doing pre-assessment of the tooth, it is probably, this is the rule that I follow, and I would advise that if we all can follow this rule, that whatever, even if it's a perforation, it's a pathological perforation we are dealing with, I have to rebuild the whole root part of the tooth. What I feel is that if nothing is possible in the presence of microorganisms, that if I do not clean and shape my root canal system nicely, I do not clean and shape the periapical area in the surgical cases, if I do not remove maximum microorganisms from the root canal system, then probably I will never be able to see healing. However, I always feel that everything is possible in the absence of microorganisms. Now, when I am saying in the absence of microorganisms, I do not say that we have to have 100% absence of microorganisms, which is not practically possible. But we should have enough cleaning and shaping done and disinfection done, so that we can help the body to start its healing process, and which will help in achieving success in endodontic therapy. Now the failure of cases do not only happen in cases of missed canals, they also happen while we are making excess cavities. Now ideally we have to make an excess cavity, and we have to go, this is how we make excess cavity, that we go vertically down till we feel a drop, depending upon case to case. Not in every case we might not feel a drop if it's a calcified pulp chamber or something, but we do a vertical cutting till the time we feel a drop. And once we feel a drop, we change our burr. If we do, conventionally we used to change, but now since I am using endo excess burrs or endo excess burrs, or I use a single burr, I do not sometimes change my burr, and I take care that I don't go wrong and touch the pulpal floor. So this is the area when you feel a drop, you should not be doing any vertical cutting. Only cutting direction should be lateral. You should be only cutting in a lateral direction rather than vertical direction. Once you do this, then there is no way that you will be touching the pulpal floor. So you are actually avoiding your pulpal floor perforations. You need to check your burr that it does not go beyond a particular length, and then do your orifice opening with conservative instruments like GG drills or ultrasonic tips. It's always good, it's always good to be conservative and use smaller instruments in cases where you are not able to locate the canal or you suspect that the canal is here. Don't be aggressive, don't go down with the burrs, because this is ideally we should be doing. If you are using an endo excess burr, then probably you feel the vertical drop, raise your burr a little which is above the pulpal floor, then do the lateral cutting and finish the walls of the excess cavity. And then you use your DG16 probe, place it inside the orifice where you suspect that there is a canal, and you try to find a catch clinically that this is your orifice of the root canal. And then you use a file to check the patency of the canal, and so on, then you proceed. But however, what happens in cases where you are not able to find the canal? We get panicked, we lose our patience, we try to use the same burr, try to be aggressive, go a little deeper, thinking okay, on radiograph it is this much deep, forgetting that the radiograph is two dimensional, and we try to go deep. Still we don't find the canal. We get more panic, we lose more patients because probably two or three patients are waiting outside, and in a hurry we try to go more deep, and that is when we lose our direction, and it becomes a cause of perforation, and our burr goes in multi directions to cause perforations, and then we feel, oh, I don't know what happened, I was doing the correct thing. Right. So this is what we should avoid, and we should probably try to use smaller instruments. Another way of avoiding this is that when you take a preoperative radiograph, you can probably see the depth from the preoperative radiograph, and you can actually mark your burrs. There is no harm in marking your burrs. We should not be overconfident. And I would like to tell you here, when I was in my masters, I used to mark my burr. I was into a practice of marking my burrs so that it doesn't go down. And do not use pens, or you do not use colors, because when you use sketch pens, then it will go wash off with your water from the handpiece. So best is to use permanent markers, let it dry for 2-3 seconds, and then use it. And then you will not lose the depth of your burr, and you will never touch your pulpal floor. And this is probably the best method that has helped me also to control touching the pulpal floor and cutting the pulpal floor unnecessarily. So this is how I learned to avoid my pulpal floor perforations. And believe me, there is when you feel a drop, there is a difference of 2 to 3 millimeters from roof of the pulp chamber to the pulpal floor. So there is no way that you will travel these extra 2 to 3 millimeters and cause such perforations which directly go into the furcation area, and which directly show you a pulsating periapical tissue, right? Or you can say a periradicular tissue, though it is looking very beautiful here, right? But probably we don't want to see things like these, and we do not want to actually go this way. Now you can see, when we am talking about excess cavities, you can see this radiograph here. The case was referred to me a few months back, and this is like a dream case. Now if you read this case, This has everything what a endodontist can ask for in a retreatment case. Suspected missed canal because it's a first molar, probably majority of the first molars have a fourth canal, so there is a reported high, there is an evidence that reports high incidence of missed fourth canals in maxillary molars. So we should be looking for a fourth canal in a maxillary first molar. One. Second, it has short obturations. Third, it has an instrument fracture in the apical area. Thankfully, the instrument has not gone beyond the apex. So it is actually at a very nice position. It has broken down. Probably it's giving a good seal. That I still do not know. We are just assuming. And since you see a radiolucency in the furcation area, I suspect that maybe there is a minor pulpal floor perforation here. So this is actually a dream case, and the patient was really motivated to save this tooth. I discussed everything with him and told him these are the things. So the treatment will take a little longer if you want to really save this tooth. Since the patient was around 37 years of age, so he really wanted to save this tooth. I started making an excess cavity. Now, when I was making an excess cavity here, I did not want to remove the proximal part of the restoration because it will help act as a supporting wall. So I started making the excess cavity and I decided not to remove the proximal wall. And the moment I entered and located gutta perchas, with the gutta perchas, I also saw a sign of very thin pulpal floor. This is what I felt when I saw this picture, that there is a thin pulpal floor remaining and probably the tissue is shining through that pulpal floor. So I continued locating my gutta perchas. I could see the buccal gutta perchas only, and I still did not move towards the palatal side as you can see in the picture here. So I continued removing the buccal side of the gutta perchas and I could see a pulpal floor perforation very clearly. You can also see in this picture. Once these gutta perchas were removed, right, the patient wanted to go because it took around 45 minutes to 1 hour to do this whole procedure, and under rubber dam it's really tiring for the patient to open. So I wanted to take a radiograph. I shot a radiograph to see what I have done, and I was surprised to see that actually while removing the both the buccal gutta perchas, means your buccal and the distobuccal canal, right, I had actually removed all the gutta percha from the canal and the palatal canal was not even touched. That was actually surprising for me. But it made my job easier that I can easily locate a palatal canal and do the cleaning and shaping. Right. Still, I had not decided whether I need to remove this fractured instrument or not. Right. But what I had thought of was next in the next visit to seal the perforation. So when the patient came in the next visit, I cleaned the pulpal floor nicely. Still, I did not locate my palatal canal. Intracanal medicament was there in the buccal canals. So you can see the perforation, the big part of the perforation here. I blocked my canals temporarily with gutta perchas and I started sealing it with MTA. Now, when I seal perforations with MTA, I use MTA gun as we all do, and but I do not press the MTA with the MTA gun. Generally, what I used to do earlier was I used to press the MTA pellet through the MTA gun and use that same plunger to condense my MTA. But what I realized was that I was not very comfortable with the tactile. I was losing my MTA, probably used to go in the periradicular area. So the best reasoning I thought was probably I'm not able to feel through my MTA gun because it has a lot of parts, so and it becomes a bit heavier. Then I changed my ways and I went towards only throwing the pellet with MTA gun and then using my plugger, hand pluggers to condense MTA. And what I realized was that it was really helpful in controlling the condensation pressure. One, second, in having a better tactile while condensing that MTA so that I do not push the MTA into periradicular area. There is no harm in pushing the MTA into the periradicular area. It's a bioactive material and it's a very good material. But the question here is that do we really need to push it? Because if we want bioactivity, it will give its bioactivity, it will start the healing process, it will have exchange of ions the moment it touches the periapical tissue or the periradicular tissue. So it doesn't need to sit in the periradicular tissue to do the bioactivity or to show us the healing potential. So I started using pluggers and I felt really comfortable while using them. Then after setting MTA, use your micro brush to hydrate the MTA a bit, which will help in setting. But when you are using micro brush, kindly please again do not apply a lot of condensation pressure. I had planned that now after doing this MTA, probably next visit I will locate my palatal canal, and that is when I will do the full cleaning and shaping, and we will see how it goes from then. So this was the MTA done, intracanal medicament placed. But when I called the patient the next visit, where MTA was all set, right? When I was gaining re-entry into the excess cavity, the proximal wall, which you can see in the upper right hand side picture, in the last appointment, it was intact. The proximal wall with the remaining core material of composite, which was bonded to the tooth structure, with the vibrations, it just came off. So the moment it came off, I saw the another perforation on the palatal side. So probably first I thought it has not happened from me, but I had not even touched that area. I was using my endodontic ultrasonic tips just to regain entry and remove temporary hair. So the moment I removed temporary, the core material came out, proximal came out. I saw this perforation, very clean perforation, not bleeding at all, lying there. So I understood that probably my colleague was trying to locate the palatal canal and was not able. So the focus totally changed toward sealing this perforation. But what I decided was that since the perforation is lying there for 1 year now, let me first, let me first locate the palatal canal and then I will seal the perforation. Because the moment I seal the perforation and the next visit I try to locate the palatal canal, then probably I might disturb MTA there, right? So what I thought was, let me start locating the palatal canal and then I will seal the perforation in the same visit. So you can see here that I am using my endodontic ultrasonic tips again. If we cannot use endodontic ultrasonic tip, probably we can also use perioscalar test. But the care has to be taken that we do not touch undesired areas. Second is we do not touch the pulpal floor unnecessarily. Right here, I am not touching the pulpal floor going deep. I am just slightly removing the palatal axial wall and going towards the center of the tooth, because ideally that is the location of the palatal canal. So once this is done, I seal the perforation, and what I do, another additional step I do is, after sealing the palatal perforation, I again temporarily block all the three canals and I flow glass ionomer cement over there. Now the rationale behind flowing glass ionomer cement on this pulpal floor was because I felt that the perforations are too extensive and probably more than 70% of the pulpal floor is MTA only. So just to keep that MTA safe, one. Second, just to provide a little more strength to the pulpal floor and the MTA, I placed glass ionomer cement so that I do not also disturb that MTA while doing cleaning and shaping. And then in the next visit, I clean and shape the tooth like any other normal tooth. Now, before doing these MTA perforation repairs and glass ionomer cement building, I had located for the fourth canal, but I could not see any fourth canal there. So I recalled the patient and I cleaned and shaped. Also, I decided not to remove the fractured instrument. The reason behind this is because the fractured instrument was lying at a very sensitive place right at the periapical area. And if I use ultrasonic tips here, probably I might be damaging the apical foramen and widening the apical part of the canal, which is I didn't feel very much the need of it. And secondly, in all these 2 3 visits which the patient had come, when he came for the very first time, he had a sinus, he had an intraoral swelling, and the tooth was tended to percussion. Now, till this stage where I did perforation repairs, I located the canals, and 2 or 3 times I had placed intracanal medicament also. Till this time, all the symptoms of tender to percussion, sinus, and intraoral swelling had subsided down. So this was showing that actually I am going on the right track, and body is also helping me to heal, helping me to achieve healing. So I continued. I did the cleaning and shaping, and I obturated the canals. Now this is the pre-op, and I firmly believe that whatever retreatment or treatment we are doing, it is half done if we do not have a proper recall, because sometimes a very good looking root canals, if we have an immediate post-op and it's a very good looking root canal, it might also fail after 1 year or 1.5 years. So it's a good idea to have a recall of at least 6 months or 8 months or minimum 1 year, right? So when I got this patient for recall, this was the healing that was happening. Patient no tender to percussion, no sinus, healing is evident. And actually the patient has to come for a crown, but this corona thing happened, and for the last 3 months the clinics were off. So probably now the patient will come, and I'll be able to have a another recall after 4 to 5 months now. So this is what you can see how we have achieved. So this was actually an example to show you that even if the tooth has a variety of endodontic mishaps like short obturations, missed canals, and you can see instrument fracture or pulpal floor perforation, still there are chances and there are scenarios that where we can actually go towards helping the tooth and the body to heal and save the natural tooth structure. So here I would like to say that from this case we have learned that probably we should be using conservative instruments like ultrasonic tips, gates glidden drills, or you can say perio tips also. If we are not able to buy endodontic ultrasonic tips, we can use perioscalar tips, which I have used initially, right, when I was not in a position to go for endodontic ultrasonic tips. So I have used perioscalar tips to do the orifice widening a bit if required, then to locate my fourth canals, and to be remain conservative. Or in retreatment cases, I do not use burrs to remove gutta perchas. I use endodontic ultrasonic tips or perioscalar tips, so that the heat is given to the gutta perchas, and my job becomes really easier, because gutta percha comes out very easily and I don't have to fight also while removing post. So the idea behind showing these videos is that it is quite helpful to use endodontic ultrasonic tips and smaller instruments, because our vision is not hampered, and at the same time we are maintain the quality of our work. Now, if you are making a normal excess cavity where you have a bulk of a pulp chamber, you can actually again use smaller instruments, remove pulpal stones. As you can see here, you can remove stone, pulps, bulky pulps, and achieve a good excess cavity and follow the laws of excess cavity preparation. Now, according to the laws of excess cavity preparation, if you see how do you access that your excess cavity preparation is good, probably when you see your excess cavity preparation, the margin of the axial wall and the pulpal floor junction should be visible to you, should be very clear to you throughout. From one corner, run like a baseball game, and complete the run, complete the journey with your eyes, and come back to the same point from where you started. So there should be no break in continuity in any direction when you see the junction of your pulpal floor with the axial wall. and axial wall should be straight. If there is a break in continuity, then it clearly means that there is a overhang lying there. Now, if there is a pulpal tissue below that overhang, then it's very easy. It can might get cleaned by your cleaning and disinfection protocols with your irrigants. But if there is a mist canal below that, overhang, then you will miss that canal, and it will be one of the causes to fail your root canal treatment. So this is how, when you move your eye from one corner to the other corner, then probably this is how it will be, look like, and all the axial wall junction should be in one line. Now, the mistakes or faults can not only happen in excess cavity preparation, they also happen after doing a beautiful root canal treatment sometimes. If we have to give a post, because ideally the post should be going in the direction of gutta percha to remove the gutta percha, make the post space, and leave 5 to 6 millimeter of gutta percha in the apical part of the canal. And perforations can happen if we lose the direction of the post drill and go in some other direction. And this we will only come to know if we take a radiograph. Until unless we don't take a radiograph, either we will come to know through the radiograph, or we will come to know through the blood inside the canal, and we will say that we have gone wrong somewhere. Like in this case was referred to me for root canal. I finished the root canal treatment. You can see three mesial canals, root canal was done, and then I had referred the case back to the colleague, because here we actually do the only the root canal if it is referred for a root canal. If this case had come normally to me, then I would have taken care of root canal, post core, crown, but then ethically it was referred to me for only root canal, so I sent back sent the patient back to the colleague. But when it came back, after 1 month or 1.5 months, probably the colleague called me and he said, Viresh, when I was making a post space, I saw blood inside the canal. So I said, okay, you send the patient back, I will see. My first question was that why after 1.5 months? So this was because patient had traveled somewhere. When the patient came to me, the first thing I did was I took a preoperative radiograph to be legally right as well as ethically right, so that I want to see what is happening, and I could see that periradically there was a lesion developing. The second thing was I asked the colleague to send me the radiograph, how he came to know that, perforation is there. So when he took this sent this radiograph, I could understand what I will see when I open this tooth clinically under the microscope. So when I opened this, obviously I could see blood. I tapped the blood with paper points. Thankfully, it was not bleeding profusely, so it was easier for me to tap it and see the perforation. So once I saw the perforation, then it's clear that I have to do an MTA repair, but I don't want to fill the whole canal because the tooth requires a post and core. Otherwise, I will have to drill the three mesial canals outward. Intercanal dentine can break. A lot of complications can happen. So I wanted to preserve this canal for post space, for post placement. So what I decided was that I will just throw some pellets of MTA and build the wall with MTA, the perforation side with MTA. So this is how I did it. And as previously I told you that I do not condense the pellets of MTA with the same plunger or with the MTA gun, right? I just use my MTA gun to throw the pellets inside, and I use hand pluggers so that I am able to control my tactile sensations as well as my condensation pressure. So once this is done, I place more pellet of MTA because you can see the perforation still there. I throw another pellet of MTA and I condense it in the same way as I had condensed the previous increment, right? But taking care, since now I am very close to the inner wall perforation, I should not be pushing my MTA a lot. I just need to settle down there, and you can see here after this I will be using paper point to hydrate it a bit, at the same time soak excessive moisture. so that it helps in setting. Once the moisture is soaked, you will see here that how the wall has been sealed with MTA in the axial direction. So the axial perforation has been sealed with MTA, and you can see here the angulation has been corrected, and I went ahead with the post cementation as well as the core buildup. So this is the immediate post-op. So once the immediate post-op was fine, the recall of the patient after 2 months was this. The patient was happy and was ready to go for a crown. He was asymptomatic. But however, said and done, the post space, it is not necessary that you have post space perforations, or we make mistakes while making a post space only inside the canals. It can also happen in the pulpal floor. Trust me, I have seen such cases that where the gutta percha has not been removed, but while making a post space, the pulp has been, cut totally, and there is a perforation here, as you can see in this case. Now this is a case that it is my one of my favorite cases, because this case made me learn a lot, and I generally show it whenever it is possible, because I want everybody to learn from it, because since I have learned a lot from this case. This is a typical endoperioral lesion with a J-shaped lesion, suspecting a vertical root fracture. And this is what the previous 10 dentists had told the patient, and I also told the patient. But however, patient was really keen on saving the tooth, and she said, doctor, I don't want to listen to this. I want to listen whether you can try to save it or not. I said, really, we can try to save it, but please understand that it can go for extraction at any given point of time during the treatment or after the treatment. And I got a consent form signed from her, because I don't want the patient to come back and blame me for her extraction if at all it happens. The challenges: calcified canals, suspected calcifications. One of the reasons why we see short obturations, inadequately obturated the canals. You can see thickness of radiopacity showing that there may be two canals, and both have been opened and cleaned and shaped, though not very thoroughly, but still something has been done. Now the thing was whether I should go through the crown or remove the crown. We decided to go through the crown, because in the pre-operative radiograph you can see they are joint crown. So if I need to cut one crown through it, patient was not very comfortable with it. So I said, okay, we will again go through the crown. Started making an excess cavity, and I said, first I always see for the signs of gutta percha. I check in between, stop, check in between, and if I feel that I need to change to ultrasonic tips, I go to ultrasonic tips to remain more conservative. Remove gutta perchas, but the moment I was removing gutta perchas from the pulp chamber, suddenly I saw something hard. Saw under the microscope there was something big silver thing. First of all, I checked my instruments, that my retreatment files have not broken. One, my ultrasonic tip has not broken. Second, when I was sure that the instruments are not mine, immediately I showed it to the patient and I said, something is there, and you can see, check my instrument, this is what I have used, and there is no breakage, so there is something underlying. I went back to the periapical radiograph, I could not see anything, right? But since patient was really cooperative, she's a nice lady, so she said, doctor, please go ahead, let us see what it is. I drilled with endodontic ultrasonic tips, and this is what I found. So the idea behind this is, the since I was following the radiograph, which is two dimensional, it was not giving me the correct picture, right? Again, I got a surprise here, as I saw in one of the first cases where I saw another buccal split of the canal, or a missed canal, you can say, right? So this was again a surprise in a retreatment case. But here I want to emphasize, many of us might think that why didn't I go for a CBCT? Now, if you are not using magnification, or if you are planning not to use magnification in your case, then probably it's a very good very good idea to go for a CBCT in challenging cases. However, if you are using magnification, half of the challenges you can actually overcome if you see properly under magnification, and half of the challenges means that you can see missed canals. If you properly do, you can see such missing posts which are not visible on the radiograph. So no need to overexpose the patient for CBCT and give him additional expenses for it. You can wait till certain point of time. Even if you want to go for a CBCT, you can wait for some time. I wanted to go for a CBCT in this case to rule out for any vertical fracture. But since the patient was so adamant and she could not afford a CBCT, so I decided to go ahead without a CBCT, and I realized that probably till this point I can do my job without a CBCT. So when I removed this post, this was the perforation right in the middle of the buccal and the palatal canal. So there was actually no pulpal floor. I decided to seal the perforation with MTA, but since I had to make a certain amount of axial walls, build them. So I didn't want to use MTA, though it's an excellent bioactive material, root repair, perforation repair material. I could have used bioceramics also, or I could have used MTA bioactive materials. But since these are powder liquid formulations, they do not have that much of strength that when I am using my rotary instruments to clean and shape the canals, my rotary instruments, the blades will erode this combination of powder and liquid and might cause micro cracks or cracks in that, which will cause micro leakage happening. Therefore I would not be able to take the help of the bioactive potential of these materials. So I decided to go for a direct glass ionomer cement where I can build the walls, and you can see in this picture that a pulpal floor is built at the same time axial walls have been built here. After that, I treated this case as a normal case. No extra canal was present. Calcified part was opened with C plus files and 10 K files by slightly pre-curving them. And you can see immediate post-op obturations here. Patient was happy. A little intrapulpal swelling had gone. Patient was not having tender to percussion, but still I had certain doubts whether I will see healing. Also, I got a perio curettage done by a periodontist here, so that since it is a clinical picture of a endoperio lesion, I wanted to have both the disciplines inside and get it an interrelated disciplinary treatment. So we did a perio curettage. At the same time, after that we went for a root canal treatment. So this is the pre-op, immediate post-op, and as I said, recall. Now I saw this beautiful healing happening. Till the time I did not see this healing, I was skeptical about a vertical root fracture happening here. But since the patient was not complaining of any swelling coming back, the pus discharge had stopped, so I was a bit confident that maybe it starts healing. But I never expected this much of healing happening. So I was actually really happy to see, and I told the patient that I would have gone for extraction. This was actually you who helped me to get motivated to treat this case, and probably the patient motivation helped me here to achieve success in clinical endodontics in this particular case. Now, when I say success in clinical endodontics, the way to achieve success in clinical endodontics is that we should realize and we should appreciate the fact that success is not a single factor responsible. It is actually a multifactorial thing where many of the factors come into one under one umbrella and help us to achieve success. One is, what is my justification, what is the operator's justification of saving this tooth. Now if we go for a case which is 90%, 99% not savable, then probably we are going in the wrong direction. So case selection and operator justification to save the tooth is really important. Now once I decide that this case can be saved, do I have enough skills? There are certain areas where I feel that I do not have enough skills, so I need to practice before I jumping. So better is that I practice first. If I want to do on extracted teeth, or if I want to do on some other way, I need to do that and then come on the patient. Magnification, yes, it plays a a lot bigger role, as you have seen in previous cases. Patient motivation, just I showed you a case where patient motivation helped me to achieve success. Difficulty level of the case, I we should be honest to ourselves, and we should appreciate the difficulty level of the case. If we feel that this case is beyond our limits, it's always good, if we want to save the tooth, refer it to a specialist, right? And then whether we have armamentarium. Now when I say armamentarium, I don't mean to say expensive armamentarium. We can actually go now, pluggers which I am using are a cheap plugger, 100 rupee or 200 rupee plugger, which I use to condense MTA, which I use to cut my gutta percha. So I don't use expensive pluggers, right? And these days the world is very flexible in terms of providing us with cheaper armamentarium. So and at the same time providing us the job that we need to do, provided we know that how we need to use those instruments, right? And then one of the most important factors is treatment planning. We need to spend some time to plan our treatment. If we are not able to plan our treatment, then probably we have chances of going wrong, or we have chances of looking for surprises and not staying planned or focused that what step we need to carry on for that particular patient on that appointment day. For example, if you see this case, now if I don't plan this treatment, then probably I would fail in providing a good quality if we don't plan this treatment. So the way to plan this treatment is first, to decide whether it has to go surgical or non-surgical. So debate with yourself on this periapical radiograph. I debate with myself or my colleagues. If you do not have your colleagues, or you are totally into private practice and you want to just debate with yourself, it's totally fine. But debate and see what challenges you would face. Right now, if I see this case, sorry, it's not periodically, it's periapically extruded gutta perchas, which is much beyond. Second is indefinite shape of the apical foramen. We can see resorption and a very wide apical foramen. I suspect inadequate apical seal because of resorption happening at the same time. Poor quality obturation. I have thin root walls, metallic post is present, and I have a PFM crown. So I have lot of challenges to overcome here, right? Now, the first thing is periapical GP. Will I be able to remove such a big periapical GP? Root canal has been done 1 or 2 years back, right? So, will I be able to remove this periapical GP in one go? Patient is having intraoral swelling. The patient is having sinus or intraoral sinus also. Second is the shape of the apical foramen. Will I be able to seal this apical foramen three-dimensionally even if I am using MTA non-surgically? I do not think so, because it is beyond my capability, and I appreciate that at that point of time that I might not be able to get a good apical seal with MTA also. So I decided, after seeing all these challenges, to go for a CBCT in this case and to go surgically. Now, why I wanted CBCT in this case was because I wanted to see three-dimensionally that what is the shape of the lesion and how much resorption is there, and what is actual shape of the apical foramen that I will be dealing with. Now, when I saw the CBCT images, I could see the extent of the lesion. One, I could see the shape of the apical foramen, so I could plan my treatment really well. I could see the extent of the lesion laterally, plan my treatment, and also make this vision, three-dimensional vision in my own mind, that when I will be doing this case surgically, the moment I will raise a flap here, then probably directly I will dive into the periapical lesion, because there is very thin buccal cortical bone which is present, or I might not find any bone, whereas palatally I am a bit safe, nasal floor I am a bit safe. So I will have to basically directly go inside the periapical lesion the moment I see. So that is how I plan my treatment here, right? So I am already ready. The moment I raise my flap, bleeding might happen. I might see the defect directly. And that is actually what happened. Mark your boundaries, see the area, inspect the areas, mark your boundaries. And the moment I opened I raised the flap, I elevated the flap, actually not raised, because somewhere I had learned that you raise chickens, you don't raise flaps. So and I'm thankful for, I would credit Dr. Gopi Krishna sir, because I learned from this sentence, I learned from him that the you don't raise flaps, you raise only chickens. So probably you only elevate flaps. So using the right terminology, so I elevated the flap and I directly went inside the defect, cleaned the defect, removed the older gutta percha, removed the peripically extruded gutta percha, and removed and cleaned and shaped with the biggest file possible and placed MTA peripically. Now, when I was able to see the peripical, shape, the shape of the apical foramen, I could easily place the MTA there and achieve a adequate seal. So this was the MTA place and this was the seal achieved. Then went ahead with thermoplasticized gutta percha here. Now, when I was planning to put thermoplasticized gutta percha, I was very clear that I do not have to put excessive pressure and condensation pressure. I am not saying that MTA is not a strong material, but it's better not to take chances. So I somehow changed the technique. I placed smaller increments of gutta perchas and condensed it gently so that it gets adapted, and I get this result after placing MTA. As I said, we should have a recall always. So once I had a recall, this was the healing that had happened, and the patient was really happy. So recall is one thing that we should be always having in terms of retreatment or treatment cases. Now, as I said, cleaning and shaping, if we do not pre-curve our files, can lead to ledge formation and eventually for perforations, right? Once first we'll make a ledge, and if we continue cutting on that ledge, then we will make a perforation here. So this is how a perforation is created, because we can't see what is happening. So it's always a good idea to pre-curve your instruments and never work in a dry canal. Keep the canal irrigated with your irrigant. Use EDTA or a lubricant, and never give a full rotation to the file while introducing the file inside the canal. So it's a very simple technique, but probably we are always less with patience, less with time, so we hurry up sometimes and we cause errors. When we do not follow these simple protocols, we end up having these endodontic mishaps like a instrument fracture here, right? So this case was referred to me where probably the canal was not adequately enlarged with 20K file, and straight away root this in a narrow canal, rotary instruments were taken inside, and maybe they were worked in a dry canal, I do not know. But there are thousands of reasons why instrument would fracture, or an older instrument was used again and again. There can be many reasons, but my job here, or our job here, is that if a case is referred to us, we need to treat it properly so that the patient is comfortable. The patient had tended to percussion, and the root canal was actually a fresh. It was broken 1 week back only. Started with, told the patient that we can remove the instrument, took working length in the other canals. Then once cleaning and shaping was done in the other canals, then I started to have a look on this instrument, and this is a clear look after drying the canal, a more closer look, so I could see the angulation. So the job here was
Hello. Sorry to interrupt. I think audio is not working. Sir, your audio is not working. There is some technical issue. Please bear with us. Just give us 2 minutes. Sir, I think your batteries are gone, might be. No, 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 not audible. Please check the mute button, sir. Please, if it is mute somewhere.
Am I audible now?
No, yes, you are audible now. Yes, all okay.
So, from where do you want me to continue?
Sir, just 2 minutes. Just 2 minutes.
मतलब 2 minutes means?
Last 2 minutes, sir. अभी 2 मिनट पहले ही बंद हुआ है, sir.
अच्छा ठीक है सो मैं इंस्ट्रूमेंट फ्रैक्चर वाले केस पे इंस्ट्रूमेंट
yes.
निकाल के जाता हूँ वापस.
Yes, perfect.
Okay. So this is how actually then we catch the instrument once it becomes loose and it doesn't pop out from the root canal on its own. Then we can use a BTR pin or a instrument catching loop and catch the instrument and lift it up from the canal, and then look out for any extra canal in the excess cavity. If we do not find it, then treat it as a normal tooth, do the cleaning and shaping, master cone radiographs, and obturate it. Right. So this is how we can make challenging cases really simple if we plan our treatment really nicely. If we do not plan our treatment, then probably we will keep thinking what to do next, and this will complex our treatment protocol. So coming to the end, again, these cases taking support from again articles. These articles always say that these are the procedural errors that prevent and control intracanal endodontic infection, but it is more so because these procedural errors do not allow us to clean and shape those areas where these errors has happened, and we give chance to microorganisms to grow and cause microbial infection. I have here we have evidence, clinical evidence, and we have seen cases where there are multiple procedural errors happened in one case also, or couple of cases, right? Short obturations are there, post perforations are there, instrument fractures are there in one case, but still those cases have shown us adequate healing. So this shows that probably it is not the procedural errors, but it is our inability to correct those procedural errors, and it is our inability to properly clean and shape the root canal system. Because even if we do not do a procedural error, root canal system is a complex system. If we do not clean and shape it properly, then we end up actually having a failed root canal treatment case. So take home message from this presentation is basically case is really important, but we need to have patience. We need to plan our treatment by giving attention to every detail. Endodontic mishap, even if it happens, it is not the end of the world. Endodontic world, you can correct those endodontic mishaps, bypass fractured instruments, remove instruments. Periapically you can remove gutta perchas, and then you can keep yourself ready for the day if you have planned your treatment. In the end, I would like to say, in these tough times, probably stay safe, stay healthy, stay mentally strong, which is very important. And actually it is our journey and no one has to travel for us. I know it is difficult times going us, we only have a choice, that is we need to travel. Now either you travel with gratitude for whatever you have, or you travel with complaint. Choice is ours. The site from the top really looks beautiful. It is really beautiful from top, but we need to appreciate the fact that to reach up to the top, we need to have hard climbs. We need to climb hard rocks. We really need to do good work so that we are able to enjoy the view from the top. And if we want to see ourselves at the top, we should face every storm. We should take every criticism in a constructive way. We should take risk, calculated risk, so that we are able to reach to the top and enjoy the view there. Social media has made the world really strong, so you can always put your doubts on social media and follow me there. And even if that is not enough, you can take my WhatsApp number from here and message me. In the end, I would like to say thanks to Dr. Abhishek, Dr. Anand, Dr. Saurabh, and the entire team of World Dental Association for this invite and giving me an opportunity to present my views here and contribute to this Endo Masterclass. Thank you so much, guys, and probably I'll stop sharing my screen now. Hello?
Now, hi, sir.
Am I
Thanks a
audible
lot
now?
for the wonderful. Yes, sir. Sorry.
Okay.
So thanks a lot for the wonderful presentation. It was really amazing. Your way of describing it is totally unique and different. It was amazing to listen to.
I'm honored to hear this. Yeah, thank you so much, Anand.
I was waiting to listen to your proper lecture. I had heard from a lot of people that he puts it across in a different way, and it was amazing.
Thank you so much. Thank you so much. Thank you so much,
Thank you
Dr.
so much
Abhishek.
for making some wonderful videos. मतलब, really appreciate it.
Thank
Everything
you.
so detailed, so clinical. Amazing. Amazing, sir. Thank you so
Thank you
much.
so much. Thank you so much, guys. Thank you for inviting me over.
Sir, it is our pleasure to have you. We have
Thank
some
you.
questions. So, shall
Sure.
we start with the questions?
Sure.
So, first question from Muniba Ansari. Do you use Metapex as intracanal medicament? And if yes, how do you remove it?
I generally use Metapex, but I have what I have realized is that it's really difficult to remove from the canal. The only way to remove from the canal is doing thorough disinfection, thorough irrigation after you have placed a Metapex. So I use Metapex in very few of the cases, not in every case, and that too also because sometimes I have it with me. But I generally use plain calcium hydroxide in the majority of my cases because plain calcium hydroxide is easy to remove, and I would recommend using plain calcium hydroxide because I don't see any more advantage of using Metapex.
Okay.
Great. Thank you,
Sir,
sir.
which ultrasonic tips do you use and suggestions for tips for refinement and tips refinement? मतलब, ultrasonic tips for refinement.
See, I don't use any single company ultrasonic tips because ultrasonic tips are from Dentsply. Also, you will get from other companies also like Woodpecker, 18th, and it depends upon which ultrasonic tip you can buy. If you can go for good ultrasonic tips, probably we can go for Dentsply, we can go for Spartan ultrasonic tips, and use StarTex kits, right? Because you can use the tips from number 1 to 5 and StarTex kits, which are excess cavity preparation endodontic ultrasonic tips. They are really good in work.
Anand, your question.
Sir, a question from Mahendra Jain. Difference between the normal mode and endo mode for scalers.
See, normal mode and endo mode differences, you might not get that much of energy in a normal mode, and you might not be able to use it for a longer mode that is recommended for endo, right? Now, I have seen in sometimes in perio scalers, the efficacy of perio scalers, if I use it for a longer time on a perio mode, the efficacy of perio scalers become less over a period of time. So probably don't try using it. Even if you have to use perio scalers, use it in small strokes, use it in smaller areas, and then probably you will be on a much safer side.
Great. Thank you, sir. So one question from Dr. Nishu Priya. Please explain what to do in cases of canal transportation.
Cases of canal transportation, then probably see the first and the foremost thing is you need to realize that you are not going the right way, and that you can only realize if you have good tactile sensation while working, right? You have to be really alert that one is ledge formation is not there at any point of the canal, and at the same time you are pre-curving your instrument so that you do not cause any strip perforation also in the inner wall of molars if you are working on, right? And then at the same time, if you are pre-curving your instruments, working in a wet canal, not in dry canals, using lubricants properly, and realizing that as you increase your instruments, pre-curving will become difficult if you are using hand instrument. So pre-curve your smaller instruments properly according to the curve that is needed, because sometimes we pre-curve but we are not able to negotiate the curve. Secondly, if you are suspecting or if you are dealing with some curved canal, then you should choose your files properly. There is no system or no file system which is the best system in the world. I have variety of file systems. I do not choose the file system, then I do the case. I first see the case, then I choose my rotary systems. Then for example, if I have to use a curved canal and I feel that we have to, curve our instruments, I need to curve my rotary instruments also. Then probably I would go for a more flexible system, and where I can pre-curve my files nicely. So that is the way of decreasing your canal transportation and strip perforations also.
Thanks a lot, sir. Abhishek.
Next question from Dr. Kiriti. Sir, any guidance from where to read retreatment endodontics as a beginner?
Kirti, you can go for, there are chapters in Engel and Cohen on retreatment. Just focus on that chapters one. But at the same time, unofficially, I'll tell you that you can see these websites also, Facebook and all these, where all of them put good clinical cases. So many clinicians are doing around the world. But be very careful, see the cases, but at the same time try to understand the planning behind those cases. You understand, we see the cases and we say, oh, he's done a good job and he's taken out instruments, but we don't realize that it needs operator skills, it needs various armamentarium. So try to think the planning, and when you have this three-dimensional thinking, when you start having, that is when you will enter the era of your own betterment. You will start becoming better on your own, and that is how you follow the cases.
Plan and implement.
Plan and implement. Yeah, implement. Yes, very right. Don't only plan, okay? Implement also.
Plan and implement.
Plan and forget.
True.
Next question from Dr. Swapnil. Sir, during removal of GP, in some cases it goes beyond apex. How to remove GP which is beyond apex?
So Dr. Swapnil, the thing is that one is, if you are doing a retreatment case, then, and if you feel while putting your rotary instrument that, or your hand instrument, that the GPs are hard, then please soften your gutta perchas first, right? Do not use force. Please do not use force in any endodontic protocol, whether it's a treatment or whether it's a retreatment. Do not use force on it, right? Soften your gutta perchas. Let the rotary file or the hand file do its job. You just have to keep your hand there and keep the instrument stabilized there. So once you have a soft GP, you have softened your gutta perchas. Second is, when you have a good tactile sensation, you are able to control your instruments, then the chances of gutta perchas going beyond the apex will definitely decrease. And even if you have cases where gutta perchas are already beyond the apex, if you go on social websites, and even I have cases where I have used endo finisher files. There from FKG, there are they come as a loop, like for using after doing finishing of the root canals after cleaning and shaping. You can actually use sometimes those files to just three-dimensionally hold that gutta percha and just pop it out. But at the same time, we have to be very strong with tactile and lucky.
Thanks a lot, sir. So quite a few people are asking the irrigation protocol for retreatment cases.
Yes, see, there is no. I know there is a big debate about irrigation protocols, and it is one of the most ignored topics also. But I am not very fussy about it. That okay, use sodium hypo, then use EDTA, then use chlorhexidine, then again go back to sodium hypo, then put saline. I am not very fussy about it. But what I take care is, one is I use my irrigant concentration properly, right? If I'm holding a perforation case, I don't use full concentration sodium hypochlorite. I don't use full flow of concentration of I control my force of irrigation, but and I take care that I give proper respect to the irrigation time. I don't shortcut my irrigation time, use my ultrasonic activation. Now majority of the cases, if you see here, I have used only sodium hypochlorite and saline. And many of the cases, when I feel I need to intervene with chlorhexidine or EDTA, I do that. But there is no indication for selection of a protocol. If you want to follow a protocol, you can follow a fixed protocol in all your cases also. It's always good you are doing. There is no harm in it. Until and unless you don't use Pepsi or Coke as an irrigant.
Or alcohol.
That is up to you. I can't speak on a social platform here.
I think we are done with today's
Abhishek.
question. Anand, do you have any other question?
All done.
Okay. In case if we have missed anybody, I think I'll request sir to go through in the comment section later on, if he is free later on.
Sure. Then probably I can answer those questions.
Yes. Thank you so
Right.
much, sir, for your valuable time and wonderful presentation. We really
Wow.
liked it a lot. It is one of the best presentations so far. Thank you so
I'm on.
much. We,
I'm honored
we
to hear
thank you
this, and
from the bottom.
thank you for giving this opportunity. And thank you, Dr. Abhishek, Dr. Anand, for sparing out time and making this platform such a good platform actually, and bringing so many good presentations under one umbrella and helping to
Thank you
improve
so much,
dentistry.
sir.
Thanks a lot,
See
sir.
you
Thanks
guys.
a lot. It was a
And
wonderful presentation. Bye-bye.
Thank you
Abhishek,
so
sir.
much.
we have one last announcement to make for tomorrow's session. Tomorrow, Sunday, we have a session with Dr. Bhavdeep Singh, sir. Uh, we will be announcing the topic and updating the details soon. Tomorrow, see you all at 11 o'clock in the morning. Thank you so much. Bye bye. Good night.
Thank you so
Bye-bye.
much. Good night, guys. Thank you so much. Bye bye.